cons side, we have Dr. Manjunath R. Kamath, Professor Chief Cardiac Consultant, KS Hegde Medical Academy. We welcome you, sir, for your talk, Beta Blockers, the Heart's Frenemy.
Good afternoon, everyone. I don't know whether my work is made easy or difficult, I don't know, because I was supposed to talk about the cons and sir was supposed to talk about the pros, and he has spoken both pros and cons. So I think first few slides will be repetition maybe, but I will try to tell in a different way. When the topic was put to me, I was supposed to talk about the beta blockers frenemy. So I went to Google and search what is frenemy. Frenemy is friend plus enemy. Correct? It's so. It's coming. Okay. So good afternoon again. Actually, I'll be talking against the beta blockers, which commonly I use in the cardiac OT. As a cardiac anesthetist, yes, beta blockers are very, very useful. As a non-cardiac anesthetist in general OT, I don't know, because we are worried about bradycardia in general sites, general cases, and tachycardia in cardiac site. That's what I believe. So if there is a bradycardia happens, suddenly all atropine, adrenaline, everything will come out, isn't it? So my core argument is, initiating beta blockers acutely before surgery, especially general surgeries, in unselected patients increases perioperative risk, including stroke, bradycardia, and mortality. It's a very, very controversial topic, and many evaluations, many things are, new developments have come over the decades, past decades. So some repetition of previous slide talks in the speak this thing. But early enthusiasm started with, I will start with a story, mid-90s to 2000. There were some small trials by Mangaluru et al. In 1996 and Polderman et al. In 1999. They told that beta blockers is like it's like everything. So if the beta blockers is there, it reduces the myocardial demand. The mismatch, demand supply mismatch won't be there. So safely we can start beta blockers in all patients. And they also they concluded that it gives cardiac production. However, this decreased trial actually, most of the developments with respect to beta blockers, it was based on this study. Actually, this investigation revealed ethical concerns, missing content, data fabrication, and protocol violations. So then it was told that it should be excluded from the modern guidelines. It is fabricated, totally false, and smaller trials also. Then actually, doubt started. So period from 2005 to 2008, then there is some problem with the beta blockers, we should not eat. Then they started these larger trials. One is the POBL, and second thing is the POISE trial. So they told, no, beta blockers are not good. So the decreased trial, whatever is there, it cannot be taken. The beta blockers are not at all good. And meta-analysis done during that period, they showed increased incident of hypotension and bradycardia. Then came the 2007 ACC and AHA, the American College of Cardiology and American Heart Disease guidelines, shifted towards more selective use. I don't know whether you can read the slides. So first, initially, you can see few studies, smaller trials at Mangaluru, all these things, they favored beta blockers. The later 2008 onwards, the landmark study, that the POISE study, it showed that beta blockers relative risk is more and it is very, very harmful. So actually the POISE trial changed everything, the concept about the beta blockers, especially in non-cardiac surgeries. So let us closely look into this POBL study, actually, periodic beta blocker trial on 103 patients over 3 years. So you can see the incidence of bradycardia is more in the patients on metoprolol, and hypotension is also more. So in lower risk patients, periodic beta blocker does not reduce cardiovascular mortality, but significantly increases bradycardia and hypertension. And there was no manipulation, data manipulations, no integrity, no misconduct, not something like that. So these were actually contrary to the findings of the decreased trials. So actually 2007, the ACC guidelines came. The strongest endorsement was continue beta blockers if the patient is already prescribed for angina, symptomatic arrhythmias. Please note the second thing, actually it was based on decrease. Start beta blockers in intermediate risk surgeries. Even for vascular surgeries, use beta blockers. However, they did not recommend the beta blockers for low risk surgery. So what is the problem here? What is the, sorry. So what they recommended is initiate beta blockers at least days to weeks preferably 1 to 4 weeks before surgery. Longer acting agents advice. Target heart rate will be, should be around 60 to 80. This decrease 1 to 4 studies, there are 4 studies, form the core evidence for recommending prophylactic beta blockers, especially for vascular surgeries. But after misconduct findings from in 2011-12, the experts begin to warn that actually this recommendation must have harmed many patients. It must have harmed many patients, and they suggested maybe there were many hundreds of thousands of premature deaths. So after that, this acute initiation on the day of surgery is discouraged, as highlighted by the POISE trial. Then the POISE trial is conducted across 190 hospitals in 23 countries, over 8,350 patients. It's a randomized controlled trial. So 2 groups were given metoprolol, other groups were given placebo, nothing was there. So what is the outcome here? They increased the all-cause mortality. Why we give beta blockers? To reduce the intraoperative myocardial infarction. They said, concluded that though it decreases the incidence of non-fatal MI, it causes hypotension and bradycardia significantly, which requires treatment. So for every 1,000 patients treated with metoprolol, it would prevent 15 myocardial infarction, 7 cases of AF. However, it can also cause 8 excess death, 5 excess strokes, and 53 patients with significant hypotension. So why it matters? The POISE trial remains one of the largest and most influential RCT in preoperative medicine. MI reduction, though there is a reduction of MI myocardial infarction, there is increased incidence of hypotension and bradycardia. And they also suggested if the patient on beta blockers, be careful because there can be other problems. We will be relying on some other like tachycardia to know whether the patient has got pain or any other problems are there. If you give beta blockers, all symptoms get masked, so that danger is there. And continue in the post-op also, and don't discontinue abruptly. So it can cause atrial fibrillation, tachycardia, so many things. This was re-endorsed by one more study, large trial, Bouri et al. In 2014, almost 9 trials comprising of almost 10,000 patients. So they observed that there is a 20% increase in the 30 days all-cause mortality, increase instead of stroke, higher incidence of hypertension, and reduce. But however, they reduce non-fatal myocardial infarction, and they warned against routine pre-op beta blocker initiation in low-risk patients especially. Then the guidelines changed. So what is the difference from 2007 to 2014 guidelines? First remains the same, continue beta blockers if the patient already on beta blockers, and it is reasonable to start beta blockers only in high-risk patients. So more than 3 risk factors, not in intermediate risk patients. Starting at the day of surgery is really harmful, don't do that. And if possible, start the beta blockers in high-risk patient. If you want to start, admit the patient, give for at least 7 days, and then post for surgery. Then, however, one more guideline came, that European Society of Cardiology, they told that actually no, not 1 week may not be enough, it should be at least 1 month before you have to start and then post the case. And recent guideline, 2004 systematic reviews on beta blockers, over 28 studies, 1.3 million patients were included in this study. Result, there will not be much of mortality reduction with the beta blockers. There can be increased risk of stroke, hypotension, and bradycardia. So what are the current guidelines? In cardiac surgery, so every day I do cardiac surgery? Yeah, definitely yes. I use beta blocker for any tachy. Inside the cardiac OT, I am worried about the bradycardia, tachycardia, because that causes myocardial demand, supply mismatch, all these things. And why I am very adventurous, I'm adventurous to use beta blockers left and right in the cardiac OT. What is the advantage there compared to non-cardiac OTs? Heart is open there. And we have a pacing box. Anything goes wrong, just connect the pericardial, pacing we can do. And inotropes with syringe pump, everything will be ready. So in cardiac surgery, definitely we can use. And in nothing works, we can do internal cardiac massage also. So that option is there. But whereas in general side OTs, non-cardiac surgery, where there might be pacing box, at least transvenous pacing box may not be there. There cannot, that and inotropes means multiple infusion pumps may not be there. That time, these high quality trials and meta-analysis show that initiating beta blocker shortly before surgery, for the tachycardia, is not good. It reduces non-fatal myocardial infarction, but increases all-cause mortality and stroke risk. Starting on the day of surgery is discouraged actually. It is not encouraged. And initiation only in patient with multiple factors, not routinely, according to ESI guidelines. And initiation reasonable only patient undergoing high-risk surgeries, that too with more than 3 factors. And initiation should be well in advance. One guideline says at least 1 month. Our ACC guideline said at least 1 week should be okay. However, continuation of chronic beta is recommended. Don't stop beta blockers abruptly. Now, this perioperative quality initiative, what they said, patient on beta blockers. So what, as a general anesthesiologist, what we should do? What are the problems? There can be blunted sympathetic response. After general anesthesia, there can be bradycardia, hypotension, which is maybe intractable to treat. So you should always watch for bradycardia, hypotension, especially under general anesthesia. Risk of stroke, because you are decreasing the BP, less than the auto-regulation, there can be chances of stroke. And delayed regulation of hypovolemia and hemorrhage. What happens? Hypovolemia, hemorrhage is there, there will be tachycardia. With the patient and beta blockers, there won't be tachycardia, I will feel that everything is okay. And other thing is underestimation of pain. There will not be any response. And awareness also, it cannot be ruled out actually. Then masking of hypoglycemia in diabetic patients. So what is the first response? Tachycardia. In general, I don't think we are worried about the tachycardia, it's bradycardia. And bronchospasm, but we don't use non-cardiac septic now, but there can be chances of bronchospasm in COPD patients. And worsening heart patients, heart failure in some patients. So important thing is now the ethical consideration. So all the guidelines are telling, what are the old guidelines before 2005, they were telling use beta blockers is good, is a friend. After 2005 to 8, friend or enemy, they were confused. After 2008, it's an enemy. We should be used very carefully. It's like a friend, good friend, but sometimes depends on the mood also, can be bad also. So you should know how to handle that. So now actually difficult to justify based on the current best practice. Such practice may be considered as a deviation from the current standard care protocols. Now in the court, actually the lawyer Google, Chat, GPT, so many things are there. Beta blockers can be given or not. So guidelines says no. In the court, they ask, doctor, whether you can give beta blockers or not, according to the guidelines. We cannot tell the theory there. You have to say yes or no. If we say one more word, some fine will be there. So very difficult to justify in this scenario. We should be very, very careful. To summarize, while beta blockers can be valuable in certain surgical patients, but the evidence does not support routine use of beta blockers in all patients. In fact, as acute initiation, especially on the day of surgery, can be associated with increases of mortality and stroke. And as sir showed actually for other response, intubation response, you can use beta blocker. There are other agents are there, Xylocard, dexmedetomidine. So why you should not use that? If you have got very good this thing, pacing box, inotropes, so many things are there, definitely you can take risk and do. But if the setup is not for all these things, then think twice before using beta blockers routinely in all the patients. Thank you.
Thank you, sir, for that well-reasoned critique of beta blocker use and its potential pitfalls. We now open the floor for a brief discussion.
Actually, I don't know, I'm a friend or enemy, I don't know. Actually, I'm in the food and bank committee. So I have given you the food actually. I think food was very good. And now actually I'm trying to wake you up. So beta blocker is that only.